So we're going to be talking about the CareTrack Kids study, Peter, and we've got an agenda for today. We'll put that slide up and we can see what we're going to be running through. But can you tell us about the CareTrack Kids study, Peter. Who is running that? Who's organising the study?
So it's an NHMRC funded study. So it's a partnership grant. So it's running for 3 years. So we've got a bunch of partners which comprise essentially the departments of health in 3 states, plus Bupa have been really generous with their support. It's been run by Macquarie University, and a lot of the operational staff are at the University of South Australia as well. So it's really a collaboration between those 2 universities. We've got essentially 5 chief investigators. One of those is Mark Harris, who's the Foundation Professor of General Practice at the University of New South Wales, so we work closely with Mark. We've got Helena Williams, who's a GP from Adelaide. Helena's also on the Primary Care Safety Committee for the Australian Commission for Safety and Quality, so she's been really useful and very good to give us advice as an operational team. Some of the structures that we've got in place to help do the study, we've got ethics approval from the college, and we've also got a thing called statutory immunity. There's a couple of names for this. It's quality assurance legislation or statutory immunity. If you hear any of those terms, they're synonymous. And essentially this is a Commonwealth scheme that allows research or quality improvement activities to be protected so lawyers can't get the data. So it essentially means that if a lawyer came to us and said, give me your data on Lemke's practice, then we are not allowed to do that. We cannot.
Again,
another
lawyer.
Yeah, another lawyer. So any identifying information around providers or participants is protected and can't be used in a court of law, and penalties for us are actually jail time. So it's a really strong and it's sort of a strong bit of legislation. It's designed to facilitate participation by healthcare providers in studies like this. Obviously, when we do our study, all the patient data is de-identified, so there's no practices and practitioners and patients will be identified.
So the CareTrack study, to look at the appropriateness and the quality of the care provided to children for a number of conditions. What do we know about how well paediatric conditions are being managed at the moment?
There's not too many studies. There was a big American study done about 15 years ago. They looked at 16 conditions and they found about half of care was delivered according to what they call recommended care, which is in line with the guidelines. There's no comparable paediatric study. We've done a study on adults where we looked at care in line with guidelines, and we found in 50% of occasions that care was in line with the guidelines. We published that in the MJA in 2012. And essentially we're seeking to replicate the CareTrack adult study to ask the question, what percentage of children, Australian children, receive care according to the guidelines? I think when you're conceptualising these studies, then often the studies, the focus is on what the providers are doing or what they're not doing in relation to care. But I think we have to acknowledge that guidelines are difficult beasts as well. So they're difficult to follow. Some of them have large document sizes. So we look at guidelines a lot. The record is 300 pages for one guideline, which is a surgical site infection one from the UK. There can be duplication and overlap. There can be inconsistent structure and content, which means sometimes they're not particularly usable documents. And this is actually part of the research as well. So I think we need to acknowledge that. Having said that, in terms of trying to determine what to look for in terms of appropriate care, they're a reasonable point to start when looking at the evidence.
So when we look at adult medicine, particularly in general practice, guidelines are often not quite applicable to the patient in front of us because of their age or because they have a number of comorbidities, and the burden of treatment when we look at a number of guidelines around one patient, a number of conditions, can become overwhelming. We do see less guidelines for children. So one of your aims of the program, would it be, Peter, to get an agreed set of indicators that represent quality practice in children?
Yeah, so the aims are up there at the moment. So the first, if we're going to measure what essentially a standard of care in inverted commas, then we need to sort of look at what that standard of care looks like. So our first aim was to get national agreement on the indicators for the management of 19 common paediatric conditions. The second aim was to then measure appropriateness of care delivered to children in a variety of settings. And then this is a new one. The third one we didn't do in the adult study. So whilst we're looking at the medical records of kids, not only are we looking at appropriateness of healthcare, we're going to look at whether there was any adverse events that, and we're doing this at the moment. It says frequency and types of adverse events. We're more really interested in the types. So what types of adverse events? What are their characteristics rather than the frequencies? Because the thresholds for measuring these things are pretty difficult to get right. So we're more really interested in the types of adverse events.
So we'll have a look in a minute, Peter, at the 19 conditions that are focus of the CareTrack study. But you said that surveyors, or it's going to be a clinical audit, is that right? What's the methodology of the study?
Yeah, it is. And so the first thing to do is develop the indicators. So what we did was we've got our conditions. We then did a big search for guidelines, and for each condition we pulled all the recommendations together for each condition from the guidelines, and then we converted them into indicators. We then did essentially a modified Delphi panel. So we asked experts to come and have a look at these indicators and give their opinion on, are these applicable, are they feasible to use for Australian kids in the Australian healthcare system for the years 2012-2013. And we got 70 experts involved. They were mainly paediatricians and general practices who were the experts for that Delphi process. So that took 18 months. It was a pretty rigorous sort of process to do that. So we've got our indicators. The next step, which is what we're doing at the moment, is we're doing a medical record review. Essentially, we've employed some experienced RNs to go out, collect the data on site from hospitals, from specialists' rooms, from paediatricians' rooms, and from general practices. So we're currently in that phase at the moment where the surveyors are out there collecting data, reviewing medical records for appropriateness and for adverse events.
So when you got the panel of experts, they were Australian experts. I guess some of the guidelines you would have to go overseas to find some of those guidelines, and the Australian experts would determine their appropriateness for Australian conditions. Would that be right?
Yeah. We mainly used Australian guidelines, and then the overseas ones were there for almost backup. But we also, like for some, we actually used even more, not local ones I suppose, but the Royal Children's Hospital in Melbourne, they've got a big thick book that we used, and so there were some local guidelines that we used as well. Often for each condition we had 3 or 4 sets of guidelines, and that was part of the challenge actually, because there was some. They didn't necessarily say the same thing, so that was why we needed our experts to help us determine what was the best path to go.
Yes, it would be challenging because particularly in paediatrics, it's not often it's probably not level A evidence all the time. It's best practice, or rather
Yeah,
than rather
yeah,
than rather than randomised controlled studies. It's difficult in children.
yeah, it is. And we found this in the adult study as well, that um, a lot of the indicators are not level 1, the vast majority, and the vast majority are not level 2 either. But you can't do RCTs on things like assessment. You know, what should you do? What does a good assessment look like? So you can't really do RCTs on that. So really, that comes down to experts deciding these are the sorts of tests, investigations, and you know, physical examinations that are appropriate for each condition.
I'm sure we're all comfortable with that in general practice. So the conditions, Peter, that you were looking at?
We started with about 30, and how we started with the conditions is we looked at sources such as beach. So they actually gave us the beach people kindly gave us a subset of their data findings for kids under 17 to say what are the most frequent presentations to general practice. We then got some hospital data, we then got some paediatric data as well, and we put all that together, got about 30 candidate conditions, and then through a process of elimination and talking to our chief investigators and associate investigators, we whittled the list down to 19. These are generally pretty prevalent. Many are national health priorities and or have high burden of disease. So that was sort of our criteria in terms of deciding which conditions to use. There's a mix of chronic and acute, so there's about 9 acute conditions there, and the rest are chronic. So they're our focus conditions, and with each of those conditions, we have indicators against them, and we have about 500 indicators.
500 indicators. Wow.
Yeah.
So that list of conditions pokes my interest, Peter, because as a general practitioner, this is the sort of thing that we see every day. So you're bringing it down to a very practical level, and I am interested to see whether I'm managing and my practice is managing these conditions well. And we'll look at the processes whereby you go in and can answer that question for me. You're also looking, as you said, for the first time at adverse events from managing these conditions.
Yeah, and this is something that I've had lots of experience in. So this has been my sort of area of expertise for a number of years. So as I said before, we're really interested in the stories behind the adverse events and what's actually happening. So we're using, as the data collection tool, the thing called the IHI Global Trigger Tool. It's well regarded around the world. We've done a systematic review on it. Before we decided to use it, we thought let's do a systematic review. There's 48 studies that have used this tool, including about 7 in general practice. It's essentially a two-stage process where the medical record is screened, and so there's a quick process that's used to just screen the medical record, and then if any of the screening criteria are positive, then a more in-depth look to see if there's an adverse event is found. I've actually published on this in Australia. So Helena Williams and I, we did a small study in southern Adelaide using this tool a couple of years ago, and we found adverse events in about 9% of the patients that we looked at, and they were all over 75. So we're using this tool as well as doing the appropriateness indicator sort of work. So it'll be really interesting to find out, to have a look at these adverse events and find out what's going on.
All right. Well, that does sound very interesting. So when my practice, Peter, chooses to participate in CareTrack study, what can I expect to happen? What will be the next step?
Yeah, so essentially, after we have an initial conversation with you, we seek consent from the practice. We're not getting, with our ethics, we don't have to get patient consent. We successfully argued that patient consent for a study this size is too difficult and too costly, and so we are getting consent from practices. On the other hand, we're not taking any identifiers away with us, okay? So we're just receiving de-identified data. So that was the mechanism by which we're sort of getting consent. So consent from the practice, we liaise with the practice and ask you, or send some data extraction instructions, because and then the practice manager compiles a de-identified patient list of patients under 17, sends that to our team. We randomise the list, okay, because we're not obviously going to collect information from all the patients, so we get a small select group of patients from that list. We then put those patients onto some software that we've got, which is the patient identifiers, not the patient names, just the patient identifiers, because we're not collecting any patient names. Then the surveyor arranges a suitable time to collect the data on site. And we're doing approximately 40 records to complete that process. All the data is de-identified, there's no personal information taken away. There's only indicator answers against, obviously, all indicators, and that process is happening at for GPs, for emergency departments, children's wards, specialist rooms, and actually hospital outpatients as well, with collecting data.
So I'll send you a full list of all my patients under 17, which may be some 100 people, and you pick 40 of them, and then your surveyor will come and manually open their records. It doesn't sound like an automatic extraction, and look through to see if they've had any of these 19, presented with any of these 19 conditions. Is that right?
So we give you a list of 8 conditions that you can extract from best practice or whatever you're using. So and we give you the mechanism of how you do the search. So it's all that process is.
So the search that we send you, the patients have that condition, or at least one of the 8 has presented with that. So the list of patients we send you, you know that of those, they've had at least one of these conditions, and then you go through and your surveyor will come and look at, they presented with that condition and what happened. Did they get antibiotics? Were they sent to hospital? That sort of thing. Is that
exactly?
Does that sound right?
Yep. And we give you a slightly different instructions depending on what software you're using. Right. So you know, because the searches are different, obviously, with the different types of software. So and then when the surveyor comes in, there's a bunch of indicators. So if the patient's got asthma, then they'll go through the record, and it'll be recorded. We'll have recorded in our database that the patient's got asthma, and so our software will on our laptop will say, right, this patient number, the asthma indicators will come up, and did certain things happen at certain times. So if the patient was under 5 years old, they had intermittent asthma, were they prescribed short-acting beta-2 agonists is one of our indicators. If they're under 5 years old, were they prescribed an oral short-acting beta agonist, etc. So there's different indicators depending on whether they're less than 2 years old, whether they're between 2 and 5, whether they're between 5 and 12 for asthma, for example. So because that reflects what the guidelines say.
So that's why your surveyors are clinical people, because they're looking at the cryptographic world of medical records and deciphering what actually happened, which can be challenging in itself. Peter, when you're speaking to practices, what do you tell them? Why do you suggest they participate? What's in it for them? What's your answer to that question?
Well, look, no one's done this before. It's a really important question. It's quite similar in the nature of what we're trying to do with some of the work that the Improvement Foundation does. So many of you will be familiar with the fact that measurement for quality improvement with the Improvement Foundation is really at the heart of a lot of their activities. This study is using measurement for research, and setting priorities about what's being done well and not so well for children's care. So this is the first time it's been done in Australia. So we're trying to set priorities in terms of what's being done well and what's not being done so well. Maybe an example from the adult study. And again, sometimes with these studies, there can be a focus on those things that are not done so well. We also reported in that study that coronary artery disease, the compliance at a population level was 90%, which is pretty extraordinary, really. And so there's a good set of guidelines. They're based on pretty high levels of evidence. There's good buy-in from the doctors involved in that disease, and there was a good result. So I think there's something to learn about what's being done well here. On the other hand, another hospital issue that we came across was prophylactic antibiotics prior to surgery. The timing of those was done really poorly. And so from that study, we can really prioritise that as at a population level rather than the coronary artery disease. So what we're trying to do is prioritise those things that are not being done as well in kids' diseases. The other reason is we've also put in a CPD program, which goes for about 6 hours. We call it the CareTrack Adverse Events Program. All the major bodies involved in general practice, there's a list there, have rubber stamped this program or endorsed it. So GPs and practice nurses and practice managers, if they wish to get CPD points, can register via this program. And you could do it as a practice. And essentially the purpose of that program is to try and get a better understanding of managing incidents and adverse events, detecting and managing adverse events that happen at practices, and it fits, and we've tried to integrate and fit it well with the college's standard 3.1 around quality and safety, or safety and quality it's called. And then the other reason to join is you can opt to receive your data back. So you can use this to understand how you're tracking against what we find nationally. So that's another reason to join in.
And so Peter, the participants on the line have been involved in organising collaboratives and participating in collaboratives will also be thinking, gee, this sounds like an opportunity to have an ongoing quality improvement program aimed at improving the care we provide for our kids. So a snapshot's good, will let us know that we're good or bad, and usually you find out we're not as good as we think we are. And then an ongoing process of measurement against your indicator set to demonstrate that the activities and changes we make are improving our outcomes for our kids would be fantastic. So developing the indicator set and validating it as being useful in general practice will be a major tool for ongoing quality improvement in this area.
So, and a recent example of that, Tony, is obviously when you develop indicators, then they can have, as you say, they can have multiple purposes, and not only can you use them for research, but you can then the work's done to use them for quality improvement. So the Royal Children's Hospital in Melbourne, who we've got a good relationship with via this project, they've asked us for, we've just given them the GORD indicators. They're doing some research on GORD in their hospital, and they thought, well, we've done the work on the indicators. They've got an electronic medical record that they're rolling out, and they just wanted our indicators and their electronic medical record and their small, it's a QI project on compliance with GORD to be all lined up, so they've used our indicators. So that's another nice example of ongoing how these indicators can be used.
Thank you. So, and just quickly then, this is the CareTrack Adverse Events Program activity that you talked about on the next slide, which is the 6-hour free quality improvement program that's accredited against all the colleges, and it's going to follow the structure that such a program is required to take to qualify for the points. So that's good. The hospitals you're at, Peter, are listed, and I see the main teaching hospital in the country, Lismore-based hospital, is included in that list, which is good, but also
Yes.
some other smaller hospitals, as Melbourne Children's Hospital and other places like that.
Yeah,
So that's
so
good.
we've tried
All
to
around the
take it.
country.
Yeah, we've 3 states, and we've tried to sample, the big hospitals and in town and in the cities, but also a sample of the regional hospitals as well.
So I think as far as enrolling general practice goes, South Australia once again is showing it's the leader in quality improvement. Your recruiting has been most successful in South Australia, and we in New South Wales are lagging somewhat.
Yeah, look, and I think we got Chris Boland on board to help us out with some of the recruitment, and I think that's helped. And we've now asked Andrew Knight and Dana Newcomb, Andrew in New South Wales, Dana in Queensland, to help us out, and they've just started. So people might get a call from either Andrew or Dana. So as I think GPs, talking to GPs probably helps with trying to recruit practices. So it's great that they've come on board.
Yes, so Andrew's hit me up, Peter. You'll be glad to know he hasn't been slack in responding to your call out. And
Thank you.
so if I want to see if the Austin Clinic's going to sign up, how do we do that?
Probably the easiest way to do that is, so there's areas that, so we've got locations where we need, that's on that slide, that's fine. But if you're interested, then probably the easiest person to contact would be Shanti. So Shanti Rabanathan. So Shanti's details are there, or you can contact me. So there's more information on the website that is noted on that slide as well.
Fantastic. Jodie's pointed out online that participation would also help practices meet their accreditation requirements. We have a quality improvement requirement to meet accreditation, so that's another selling point. But Peter, I think that the reason we would want to do it is because that we aspire to be one of the best practices managing paediatric conditions, and unashamedly want to demonstrate that. And many of our practices respond to that sort of call-up. So practices want to participate. There's the participation numbers for the CareTrack. So if anyone's got any questions from those online, they could put their hand up by pressing a little button on the click panel, or type their question in there. And Peter, so the study has started. Where are you up to at the moment?
Yeah, it has started. So we've got our surveyors. We've done the indicators. We're now in data collection mode. So we've got our surveyors employed. They're out at hospitals. They're out at general practices, collecting data and recruiting as well. So yeah, we're right in the thick of it.
Fantastic. Well, that's good, Peter, and I hope that it sounds like a most worthwhile program, and one that we'll be keeping a keen eye on. I hope that we can recruit quickly to it so that we can start to see the results. What's your time frame? What are you expecting? When are you expecting to have some? This might be a bit of a difficult question. You don't have to answer it. When do we expect to see some preliminary results?
So I think the practices will get data before the end of the year, and then we'll report data sometime next year. We're pretty certain.
Oh, that's good.
Yep.
Well, that's quick.
Yep.
I'm sure the practices will be keen to have your follow-up on what they do quite quickly.
Yeah.
And is there a cut-off time beyond which you're going to close off registration for the program?
Yeah, look, we've still got a few months. So, we've still got 3 or 4 months. So there's plenty of time.
Well, thank you very much, Peter. I think our lightning lunchtime time is up for this session, and we'll make this available as a podcast online on the qiCommunity website and distribute it to other practices who are participating. And we look forward, we might get you back, Peter, next year then when the results are out, to find out what we had Bill Runciman tell us about the adult CareTrack study, and we'll be looking forward to hearing from you how well we are managing our paediatric population in general practice in Australia.
Thanks, Tanya. We'd love to. And look, thanks very much for having us. And Alison, thanks very much for organising. Much appreciated.
Thanks very much, and thanks very much for all the participants online. There's just a few things, housekeeping to let the participants know about. We've got some chronic disease prevention workshops run by the Improvement Foundation and funded by South Australia Health. So for those in South Australia, 21st of May, 4th of June, 18th of June, Mawson Lakes, Adelaide, and lovely Happy Valley. And you can contact Alison to find out more about those chronic disease prevention workshops. The Navigating the Digital Health Incentive webinars, we've done a number of these, and there are more to come. There's a webinar series and an IT support packages. The next session's coming up on Tuesday the 17th of May at 6 p.m. and that'll be repeated the following day at lunchtime for those who are keen to make sure they're uploading their shared health summaries during this 3-month period starting on May the 1st. And we've certainly started uploading them again in our practice. I'm sure David Guest is right into it in his practice. The next qiCommunity webinar will be the 24th of May, so it's in about 3 weeks' time, and that'll be part 2 of the conversation between Chris Boland and Andrew Knight on the early detection management of chronic kidney disease. Thanks very much for attending. Thanks very much, Peter and Alison. We've got some evaluation forms that will pop up after this webinar right now for those who are listening to it live. For those who are listening to it on podcast, get ready to download the next one, and thank you for joining us. See everybody. Bye-bye.